All right, let's just get right into it. We're skipping the small talk today because we need to immediately immerse you in some seriously high-yield, board-level clinical simulations. This explainer is engineered to stress test your diagnostic accuracy and your management sequencing, especially if you're targeting that perfect 270-plus score. We're going to be covering advanced communication, pediatric neurocognitive kinetics, and narrative medicine protocols. Let's get to work. First up, delivering devastating clinical news. You know, patient-centered communication isn't just some vague art form, it is a strict, learnable clinical skill. The SPIKES protocol is your mandatory structured sequence here. You've got to consciously set up the interview, assess the patient's perception, obtain their invitation to share the data, deliver the knowledge, address the subsequent emotion with empathy, and finally summarize. If you skip a step here, you are practically guaranteeing a breakdown in the patient-physician alliance. So when you're navigating profound denial or anger, you've got to algorithmically anchor the encounter using the nurse mnemonic. Name the emotion, understand it, respect their efforts, explicitly state your support to convey non-abandonment, and explore by saying, "Tell me more." Unacknowledged emotion will actively derail your clinical encounter. Remember, emotion happens way faster than rational thought, and it's entirely involuntary. Now here is the absolute trap in these encounters: offering premature reassurance or quoting survival statistics before you've validated the patient's emotional shock. You simply cannot fight an involuntary emotional reaction with biomedical data. If you throw statistics at a patient who is in active shock, you're going to alienate them immediately. Okay, what happens when a patient definitively lacks decision-making capacity and has no durable power of attorney or living will? Well, you must rely on the strict legal hierarchy. Think of the mnemonic SPOUSE, C-H-I-P-S. Spouse, then adult children, then parents, then adult siblings. You do not jump to a court order if a recognized surrogate is available, but you absolutely must consult them in this exact order. Let's look at the clinical variance between denial and acceptance. Denial is an unconscious psychological shielding mechanism, right? It drives painful reality completely out of awareness. Sure, it preserves the patient's good feelings in the short term, but it severely delays medical planning. You manage this by using that NURSC Explorer protocol we just talked about. You do not aggressively confront the delusion. Acceptance, on the other hand, allows you to transition right into the strategy phase and start mapping out advanced directives. All right, time for our first integrated assessment. We have a 78-year-old male who is currently intubated and sedated following a severe ischemic stroke. He definitively lacks capacity. Now, he has a legally binding written advance directive explicitly refusing prolonged mechanical ventilation. However, his daughter, who is his legal surrogate, is incredibly distraught, and she demands that you keep him on the ventilator indefinitely. So, what is the most appropriate next step in management? You've got 5 highly competitive options to weigh here, do you? A. Follow the surrogate's wishes and maintain ventilation. B. Prioritize the written advance directive and prepare for extubation. C. Convene the hospital ethics committee for mediation. D. Seek a court order to revoke the daughter's surrogate status. Or E. Administer a trial of spontaneous breathing before making a decision. The crucial point here is that prioritizing the written advance directive is absolutely the correct move. A legally executed advance directive is the ultimate expression of patient autonomy, and it 100% supersedes the demands of a surrogate decision-maker. Following the surrogate's wishes is an ethical violation. Convening the ethics committee is unnecessary because the legal directive is already crystal clear. Seeking a court order is an inappropriate escalation, and a breathing trial just delays legally mandated care. Moving right along to Module 2, we're shifting gears to pediatric OSA and neurocognitive kinetics. When we talk about the pathophysiology of pediatric obstructive sleep apnea, it's overwhelmingly driven by adenotonsillar hypertrophy, typically peaking between ages 2 to 8. But here is the critical distinction you have to remember. The resulting nocturnal hypoxia and fragmented sleep architecture completely bypass the standard adult presentation. Adults get daytime somnolence, children usually do not. Instead, the pediatric clinical signature manifests paradoxically. Sleep deprivation in kids results in severe hyperactivity, inattention, and declining academic performance. It heavily, almost perfectly mimics attention deficit hyperactivity disorder. Night terrors, chronic mouth breathing, and secondary enuresis, bedwetting, those are your absolute red flags here. Because this is literally a structural obstruction, the management protocol is super strict. You confirm the diagnosis via an overnight sleep study, right? Polysomnography. And the definitive first-line intervention? Surgical adenotonsillectomy. The beautiful thing here is that surgical correction of the hypertrophic tissue frequently reverses the behavioral and neurocognitive deficits entirely. It's a total game changer for these kids. Differentiating these variables is absolutely critical. Primary ADHD lacks nocturnal respiratory obstruction. There's no snoring, gasping, or choking. It's an isolated behavioral deficit requiring CNS stimulants like methylphenidate. Pediatric OSA, however, presents with loud snoring and restlessness during sleep. Prescribing a stimulant to a child who is actually suffering from chronic structural hypoxia, that is a catastrophic clinical error. Let's test this with our second integrated assessment. A 6-year-old male presents with declining school performance, hyperactivity, and inattention. Sounds like classic ADHD symptoms, right? But the parents also report he is highly restless at night, frequently gasping and snoring loudly. What's the most appropriate next step in management?
Here are your 5 options, heavily weighted with standard ADHD interventions. Do you initiate methylphenidate? Initiate dextroamphetamine? Refer for behavioral therapy only? Order an overnight polysomnography? Or reassure the parents this is normal? You've got to correctly differentiate between a primary psychiatric disorder and a secondary neurocognitive deficit here.
And the correct move here is to order an overnight polysomnography. Initiating stimulants or referring for just behavioral therapy or TRAPS, they prematurely anchor on an ADHD diagnosis while completely ignoring those glaring nocturnal respiratory red flags. Reassuring the parents is negligent. Functional impairment in school requires investigation. The presence of snoring and gasping mandates a structural airway evaluation to rule out OSA before you even consider initiating CNS stimulants.
All right, let's hit our final module, narrative medicine and clinical empathy.
Narrative medicine isn't just a soft skill, it's a deliberate discipline. It requires shifting your clinical focus from simply extracting data about a diseased organ system to actively absorbing the patient's subjective functional priorities. Early goals of care discussions absolutely mandate mapping out the patient's values before you even propose a therapeutic plan. You really must strictly utilize open-ended elicitation. Asking, "Can you tell me more about what is most important to you?" bridges the biological data with the patient's lived experience. Crucially, active listening mitigates the countertransference trap, ensuring you don't project your own emotional history onto the patient. This disarms hostility and heavily reduces clinician frustration when you're dealing with really complex presentations. When we contrast these approaches, the biomedical model isolates the organ and focuses purely on extracting data for a pathophysiological intervention. But narrative medicine captures the functional impact of that disease on the patient's daily life and identity. Integrating the narrative approach actually aligns the patient with the treatment plan, which yields vastly higher medication adherence and overall patient satisfaction. Let's apply this in our third and final integrated assessment. You have a patient with advanced treatment-resistant cancer who angrily tells you, "None of you doctors are helping me. Isn't there anything else you can do?" This is a classic high-tension scenario where profound emotional distress is being masked as a cognitive question about treatment options. So, what's your most appropriate initial response here? Is it to say, "We have exhausted all evidence-based chemotherapy regimens"? Or, "I understand exactly how you feel right now"? Or, "Can you tell me more about what is frustrating you"? How about, "We should discuss transitioning you to hospice care"? Or finally, "I will consult with oncology to see if any clinical trials are available"? You have to correctly apply the empathy algorithm here over just offering data. The correct response here is asking, "Can you tell me more about what is frustrating you?" Offering data, transition plans, or consulting clinical trials, those are classic biomedical traps. They prematurely offer data or false hope before acknowledging the patient's emotional shock. And saying, "I understand exactly how you feel" is a massive error in clinical empathy. Presuming total understanding of someone's unique grief is incredibly alienating. The correct choice strictly utilizes the NURC Explore principle to validate the emotion first. It's honestly the only clinically sound method for disarming that kind of hostility. I want to leave you with a provocative final thought to mull over. As you review these simulations, ask yourself, how often does our rigid adherence to the biomedical data blind us to the actual narrative reality driving our patients' non-compliance? Mastering the data is just the baseline. Mastering clinical communication is what actually saves the patient. Study hard, integrate these concepts, and I'll see you in the next explainer.